So good afternoon, and I welcome you all for the final symposium on oncology in Respire 2025. So in this symposium, we have three esteemed speakers who are going to deliver their talks and share their expertise with us. So without wasting much time, we will move on to the first talk. The first lecture is on lung cancer screening, sharing experiences from UK. So it's my pleasure to introduce Dr. Jaymin Moorjaria, consultant respiratory physician from Royal Brompton and Harefield and Guy St. Thomas's Trust, United Kingdom. And on a personal note, I had the privilege to be trained under Dr. Moorjaria during my stay in the UK in my overseas training. And it's glad to have you here, Jaymin, and stage is yours.
Right. Thank you very much. It's my second day and the second time on the stage. Thank you very much to the organizers. Thank you very much for having me here. And I will try and pronounce this correctly. It's Ayu Bhavan. I think I didn't say that yesterday, so I'm trying to say hello or something. But I will try my best to do the thank you at the end better. Okay, so my remit today is to talk about lung cancer screening and our experience more from, when we say UK, more from what we do actually in West London, but how it actually evolved. These are my conflicts of interest. And just a bit about what we will cover is about the background of lung cancer screening and the pivotal studies associated with it. The program, as I said, from West London, where we are operating from, and what that involves in terms of patient pathway, the challenges, and what the future directions will be. So lung cancer, as we know, all came pretty much from this study that was published in the BMJ in the 1950s from the mortality in doctors in relationship to their smoking habits by Dole and Hill. And it became very clear that tobacco smoking was one of the most important causes of the development of lung cancer, and that includes smoking any form of tobacco, so cigarettes, shisha, any pretty much way, and in any pretty much way that the patient can consume it. They also showed, it's shown over time that there is an association with the development of lung cancer to the amount of the period on which the tobacco has been smoked, whether the filtered cigarettes have been used, and various other factors about, pack years, age of onset, etc., etc. So there's quite a lot of evidence on that. I don't need to talk to you about that. But more importantly, trying to get to the premise of why all this came into existence is it is the second most commonest cancer globally. Lung cancer is, with more than 2.5 million people affected in 2022. In the UK, more than 40,000 cases identified every year, and overall there's a mortality in 2023 of about 1.8 million globally. So it's quite a common cancer, and you can see why we would need to think about how to improve the prognosis of these patients. Because if we detect the lung cancer more in the later stages, so stage 4, the survival is less than 1 in 10 at 5 years, whereas if we detect it at stage 1 and 2, the survival rate is more than 6 in 10 at 5 years. So there's clear benefit in identifying what is something that is possibly easily managed if we pick it up early. So basically, that's the remit of what I say in my first line. And if we identify the cancer before we get any symptoms, again, that's a very good thing for the patients. So it all stemmed from this study. There was a lot of evidence to, we know that there was association with tobacco. We want to try and improve prognosis. How would we do it? And the Americans got there first, like they do with most things. So it was the National Lung Screening Trial that they held over 33 sites, more than 50,000 patients who were randomized to receive either a chest X-ray or a CT scan on an annual basis for a 3-year period. And what they managed to show was a massive improvement or reduction in lung cancer mortality of 20%, which is quite significant. But it didn't come so easily. So there were loads of false positives. There were issues with how the study was run. But overall, it showed that where there's a will, there's a way, and there is possibly a way of, trying to address this problem, especially in patients who had high risk. I forgot to say the patient cohort was at least 20 pack years of smoking, current smokers, previous or quitters. This went on. We did another study. Well, not we, as in another study was done. The Nelson study done in Europe it was a combined study with the guys from Belgium as well as Netherlands. Over 15,000 patients, and they managed to show in a similar group. So they were randomized to receive a CT scan or a chest X-ray at year 1, year 3, and year 5, 5.5 years. They chose a slightly different tobacco exposure, but essentially it was not too different, but high-risk patient, could be smokers or quitters. And they showed that there was a 26% reduction in males and just under 40% in females. So you can see there was a dramatic change. And they had, the way they designed their study, because they sort of were quite careful in their selection and how they did it, they felt there was less false positives and there was a better outcome for the patients. So, significant reduction in lung cancer in these patients. This formed the premise of the UK thinking about how they would start it. And it started in 2019 with a total lung health check program, which was run over a number of sites. And these are the sites. There were 23 sites. And they managed to invite just over 160,000 individuals. 70 plus thousand scans were done, and only 1,000 cancers were identified. But that improved what we could currently do, because our current identification rate on the 2-week wait system, the faster diagnostic pathway, whichever way you look at it, for stage 1 to 2 was about 36%, whereas this improved to about 77%. And I'll show you that in my next few slides, sorry. And this formed the premise of the National Lung Screening Committee saying, this is something we should go ahead with. And the ball started rolling in 23-24, where this was going to be something that would be taken up all over through England over the next 6 years. And this was the rolling phase. The reason why I show you it is this is something I was talking to Aarti, who's in the crowd somewhere, about how this is something that you can start off with. Very busy slide here. The idea is to show that there are more than 2 million scans done at the present time between 2019 and 2024. I'm going to concentrate more on the second or the lower table. And what I want to show is the uptake rate. So inviting so many people, only the uptake between the whole period, between April 2019 to September 24, I think it's 5.5 years, was 47%. So people do not take this up despite quite a lot of enticement, which I'll go through in some of the other slides that I'll present later on. The initial scan invitations went out to just over 47%. So there was similar amounts. However, only 43+% actually took it on. And you can see that these numbers weren't too different whether you looked at them and looked at things in the previous 1 year, so that's October 23 to September 24, or in the last 3 months. Minimal changes. But what has remained steady, like with the uptake, is the amount of cancer that we find. So just over 1%. And again, just repeating, you can see from this pie chart that stage 1, 2 is nearly 75 to 77%, whereas what we could initially identify was just under 36%. So a 40% improvement in diagnosis of stage 1 to stage 2 disease, which we know would potentially improve the prognosis of our patients. So as the program got approved and things went forward, different parts of the country were sort of given the task to take on the lung screening, which is still under the banner of TLHC, as in Total Lung Health Check. And we in West London have 3 main centers, which is Harefield, Imperial, and St. George's, where the screening programs take place. And we cover this area, which has got their own individual small district general hospitals and tertiary centers. This is how we try to invite our patients. So it's various forms of advertisements, whether it's on the news, in the television, radio, newspaper articles, billboards. It's not just about Caucasians; it's about multi-ethnicity. You can see pictures where there's different ethnic, individuals shown. Just to try and entice our patients to try and attend and take on this program, which has potentially got benefit for them. What actually happens in the total lung health check, which is going to change its name from April to the lung cancer screening program. The new sort of banners and stuff are being designed for that, and that will come very shortly. So it's offered to patients who are aged between 55 to 74, mainly derived from the primary care data, current who have smoked at least 20 to 30 pack years, current smokers or quitters in the past 15 years. The only exclusion, though this is not always achieved, is patients with poor health and significant comorbidities, and the inability to attend, to have surgery per se. So you want to try and get the patients who actually will benefit from what is being offered. So what happens is the patient receives a letter, the patient is interested, they will make a phone call to the triage center, and they will be triaged or given a date for triage calling, which is used. The prediction models are used. So there's a standardized questionnaire that they will be offered. If they qualify, then it goes to a nurse appointment where further prediction model questioning is done. And the patient, if appropriate, will be offered a CT scan, which can be on the same day or on a different day that is suitable for the patient. The CT is then interpreted the contract is actually being set out to a private company called InHealth or HLA and HLH. And basically they have AI technology. So they will, for pulmonary nodules, and there will also be a radiologist who will interpret or will make will report on the scan. If there are any abnormalities, then these will be referred to the screening review meetings, which are held on a weekly basis. So we have 3 meetings, one for each site on a weekly basis, and appropriate referrals will be made. So depending on what is found in terms of not only pulmonary abnormalities, but any other abnormalities that will be identified. So these are 2 risk prediction models that are in the literature, which is the Liverpool lung project and the prostate, lung, colorectal, and ovarian models. The second one is from the United States and part of their screening study that they did. And the previous, which is the Liverpool one, is from Liverpool in the United Kingdom. But what the NHS has done is they've used a composite model through the NHS X service to devise something that is more appropriate for the population that we have. Who is present in these meetings, the screening review meetings? There is going to be a responsible assessor who is normally a middle grade or a senior nurse, a responsible radiologist, a responsible clinician who is overseen by a clinical director. So for the 3 sites that we have, this is our team, so 3 people minimum on each site, and a clinical director in charge. And this is bookended by the targeted lung health or the lung screening program, SOP, as well as the quality assurance and quality assessments that we do on these patients in terms of what we find and how we refer the patients. So we are monitored in that way. Challenges, we're always going to find some false positives. And how do you deal with that? It's quite difficult. Patients get very anxious. There might be overdiagnosis of patients, indolent tumors that may not necessarily need or cause a problem. And I'll come to that in the following few slides and a few studies and challenges. We need to make sure it's accessible and equitable to everyone, which is something that you would want to consider here. And this is, again, one of the things I was discussing with some of you. There is obviously a cost to it. However, I'll show you some cost models It's not that expensive per se once it is established. The only cost allocation is when we get a false positive or if you find obviously a pathology, but that's why we're doing it. And the other thing is to try and encourage patients so that they adhere to the screening program and attend for the follow-up scans. So that's one thing I didn't tell you on the patient pathway. If there is no abnormalities, they will be re-invited after 2 years for a further scan, irrespective of whether they're smoking or not smoking, and they have to fit the age criteria. There are ethical things that we need to consider. What is the risk and benefit to the patient? Well, I've shown you quite a lot of benefits. The risk is obviously, you will possibly over-investigate patients if you find an abnormality. Communication needs to be clear so that the patient is aware why and what is happening, because there can be a lot of confusion and complaints can happen. And you could run parallel projects or parallel screening programs alongside. And the one that we are sort of doing is the smoking cessation, but you could run other programs for screening that could run side by side with this if you're planning this here in Sri Lanka. Couple of studies I want to show about what challenges may be present. Is one that would probably apply here is the ethnic and socioeconomic status of the patients, because that could undermine, because the knowledge or understanding of why this is happening may be an issue. And in the study on the left, that was one of the reasons why there was an under recruiting or under par allocation of patients on the lung screening program that they were held locally. There's also the issue of overscreening in patients with loads of morbidity and frailty, because the chances of you offering something curative to them is going to be quite low, because they probably won't be suitable for surgery. So you really need to think about how you're going to get your cohort of patients that will help. So these are a couple of tables. The top table, table 16, it's not it's table 1 actually, but it's 16 because I've copied it from the SOP. It doesn't cost that much once you're running the program. But if you find a false positive, the cost can be quite differential depending on what is offered, who is involved, what investigations, treatments, etc. Where do you think things will go in the future for us? Well, AI is taking over the world, as we all know. And there's going to be better and advanced imaging as well as diagnostics. We can probably try and better the risk profiles of our patients to get a better cohort of patients allocated into the screening programs, and integrating them, as I said, combining it with other initiatives or screening programs may be the way forward. The other thing is to involve the private sector and see how they can help in trying to facilitate better health for our population as well. Here is at least 8 or 9 AI projects that are currently running or have completed. So they involve various aspects of health, so COPD, coronary artery disease, genetic screening. You can see that it's the world is your oyster. There's so many sponsors down at the bottom, all in the NHS. So to try and conclude, I have hopefully shown that lung cancer screening can help, though in terms of saving lives and early diagnostics, though we need to implement the program carefully and appropriate patient selection. We need to also take into account the challenges that we may face in trying to get an effective model that is accessible and equitable to everybody in the population. Before I take my seat and conclude, I'd like to acknowledge our director, who's been very helpful in providing me with some of the data, as well as Jane Derbyshire from the Royal Marsden Partners, as well as my colleagues from the various teams at the SRMs in the 3 centers. Thank you very much. And I'd like to say this, and hopefully I can get the pronunciation right. It's Bahoma Stuti. I probably didn't get it right. Yeah, thank you very much.
Thanks, Jaymin, for that excellent talk and also sticking to the time. And to introduce the second speaker, I'll hand over the microphone to my co-chair, Dr. Saman.
For the next lecture, I would like to invite Dr. Dhammike Rasnayake, consultant thoracic surgeon currently attached to National Hospital for Respiratory Diseases, to give us a talk on the utilization of minimally invasive thoracic surgery in lung cancer practice. Over to you, Dr. Rasnayake.
Good afternoon, everyone. And let me thank organizing committee to give me the opportunity to talk on the utilization of minimally invasive thoracic surgery for lung cancers. I don't have any conflicts of interest. You can see 2 types of surgeries. This is first one on in your left-hand side. It is open surgery with tactile sensation with direct vision. On the other hand, there's another surgery. You don't have tactile sensation with keyholes, small keyhole incision, and you do the operation with vision with help of video camera and television. So purpose is same. So what is your choice? Let me show we'll see the answer. Right. There are two types of minimal invasive thoracic surgeries for lung cancers. One is so-called video-assisted thoracic surgery. Other one is robotic-assisted thoracic surgery. Nowadays, the video-assisted thoracoscopic surgery is the gold standard for lung cancer resections. In major centers, more than 80% of their lung resections done via video-assisted thoracoscopic surgery. It has comparable surgical outcome with high quality index. On the other hand, robotic assisted thoracic surgery need more advanced technology, and it is a growing adaptation worldwide. Special feature is it has 3D visualization and improved instrument articulation. It is particularly important for major resections and especially for mediastinal resections. You can see that basic difference of basic instrument we use. On your left-hand side, this is basic VATS instrument, but in contrast that this is expensive robotic instrument. They have very high range of articulation. What are the benefits of minimal invasive thoracic surgery? Key clinical benefits are it reduces postoperative pain. So invariably, it reduces the requirement of analgesics, especially opioids, because those are the main things affect the underlying disease and other comorbidities. It has significantly reduced shorter hospital stay as well as ICU stay, faster return to the normal activities, a lower wound infection rate, and decreased blood loss. Sometimes after minimal invasive lung resection, we just bleed only 5 to 10 ml and improve quality of life score and better preservation of pulmonary functions. So it is very important to have this kind of surgeries for patients with limited lung capacities. Further, there are many oncological advantages. We have unequal lymph node harvest rate compared to thoracotomy and no compromise in oncological outcome and better compliance with adjuvant therapy. Let me explain those. Primary applications of non-small cell lung cancer, the minimal invasive surgery are diagnostic purpose, staging, therapeutic, and palliative. The gold standard of treatment for lung cancer is resection. Surgery is for early lung cancers. When you consider the surgery, it may be vary from lobectomy is the ideal surgery, but you can do minimal lung preservation surgeries like segmentectomies and even pneumonectomy. Our main aim is to complete resection of tumor, including the adequate bronchial resection margin and parenchymal resection with adequate mediastinal and hilar lymph node clearance. Which resections? Which resections are mainly reserved for biopsies, but patients with a lot of comorbidities as well as severely deprived lung reserve, you can consider even wedge resections for treatment as a treatment. But generally, lobectomies and segmentectomies are the treatment, because when you do the lobectomy and segmentectomy, so-called anatomical resection, you dissect around the blood vessels and bronchial system where the lymph nodes are. because then you clear the tumor as well as lymph nodes. This is a special situation. Indeterminate nodules. You can see in this CT scan, this one belongs to 45 years old lady. You can see there is a this lung nodule. Can you play? In upper lobe, it's mainly lie over the heart. This sort of lung nodules are very common in our population because we have many other reasons for lung nodules, such as tuberculosis, fungal infections, silicosis, and other inflammatory diseases. We get many patients. In this sort of patient, sometimes there are challenges to get a biopsy. And most of the time, biopsies are inconclusive. So what is the next step? So next step is, ideal thing is, we do video-assisted thoracoscopic wedge resection and do the frozen section. Then we can come to a conclusion whether it is a malignant or not. If it is malignant, during same anesthesia, we can go ahead with curative surgery. That is one indication. And like in this patient, this is again 45 years old lady, presented with an upper lobe lung nodule. So this is just wedge resections. Look, you can see this video-assisted thoracoscopic wedge resection. Feel the lung nodule and get the nodule out with adequate resection margin. Luckily, it came as tuberculosis. So then you don't need to do surgeries, but this is the way you have to tackle nodules with indeterminate origin. On the other hand, we can treat lung cancers with wedge resection for patients with severely deprived lung reserve. Lobectomy is the main treatment for lung cancer. This is one of our patients, 65 years old gentleman with right upper lobe lung nodule. So our main aim is to dissect lung parenchyma carefully with blood vessels. And here you can see there are mediastinal lymph nodes we harvest during the resection. We need to do clear lymph node clearance, and this is superior pulmonary vein. Dissect around the vessels while clearing the lymph nodes, and we take lymph nodes for sample as according to the stage, and then divide the blood vessels with linear cutter staplers. Those are endolinear cutter staplers. While dissecting, they seal both ends. Next step is pulmonary artery dissection. Around pulmonary artery also, there are a lot of lymph nodes. We can have very good visualization with minimal invasive surgery because that we do operate under 5-time magnification. So that is why we can have such a good clearance, more than, I think, open surgery. It's very comfortable to operate with a keyhole surgery because with that magnification, you can see that all the lymph nodes come out with the tumor. And this is bronchus. You can see this black colored dots. These are lymph nodes. And we take all the lymph nodes with the tumor carefully when you dissect. So this is bronchus. Bronchus also dissected and divided by endolinear cutter staplers. Again, take all the lymph node, all the other pulmonary artery branches. You take all pulmonary artery branches and finally the parenchyma. Again, another pulmonary artery branches. So the important thing is you can see minimum blood loss. And this is parenchymal resection. Parenchyma and bronchus, you need to have adequate margin for oncological resection. Finally, this lobe will come out in a bag to minimize the spillage of tumor cells into the pleura. And we wash the pleural cavity thoroughly with warm saline or warm water to destroy if there is any spilled out tumor cells. You can see we are taking the tumor out in a bag. This is the tumor after it's taken out. And especially when you do dissection around the pulmonary arterial dissection, you have to take all these tiny lymph nodes. You can see here clearly these lymph nodes should come out. And further, not only the intrapulmonary lymph node, the mediastinal lymph node dissection also part and parcel of this operation. And other thing, mediastinal lymph node sampling versus mediastinal lymph node dissection. These studies has proven mediastinal lymph node sampling is adequate for early stage lung cancer. But in our case, it is different because we don't have a screening program. Most of our patients are presented with very advanced stages. In advanced stages of lung disease, the occult N2 disease is more common. So because of that, our main practice is to complete the complete lymph node dissection during the surgery. You can see here this superior vena cava and this esophagus, and this is just lateral to the trachea where this place, and that is R2 and R4 lymph nodes we dissect completely. And again, same mass. This is station 7 lymph node, subcarinal lymph node dissection. All the lymph node dissection should be done clearly without leaving any lymph node, particularly when the disease is advanced. And at least you have to take out 3 stations of lymph node whenever you do lung cancer surgeries. So this is the evidence for advances of minimal invasive surgery. It minimizes the chronic and acute pain and short length of stay, and low postoperative morbidity and mortality, less intraoperative bleeding, minimal local regional recurrence, less morbidity, fewer complication, rapid return to the functions, and comparable 5-year survival rate with long-term survival. Further, it improves the discharge independence in all patients and patients in high risk. So that is why the keyhole surgery, minimal invasive thoracic surgery, is more important for patients with lung underlying diseases as well as old age patients, elderly patients. And other important thing is it improves the ability to complete the post-operative chemotherapy regime. So surgery is one part of the surgery, but one part of the treatment range. But following surgery, they need to undergo chemotherapy for complete or good outcome. So most of the time after keyhole surgery, their compliance for chemotherapy is high, as well as interval between surgery and chemotherapies we can reduce, because that is very important for improve the survival. Yeah, that is about lobectomy. What about pneumonectomy? Is there any role in lung cancer surgery? Yes, but it has its own problem. Like pneumonectomy has very high in-hospital and post-operative mortality and morbidity. So all the time as thoracic surgeon, we would like to avoid pneumonectomy. So what are the options for that? Is we do sleeve resection. Sleeve resection is like in this patient, you can see it is a tumor associated with secondary carina of left lung. So this sort of case, easy option is pneumonectomy. But there's another option, that is we can take the tumor out from the proximal main bronchus and distal interlobar bronchi. And we anastomose both proximal main bronchus with distal interlobar bronchus together. So even this kind of operation can be done thoracoscopically. Not only the bronchi, and even blood vessel resection and reanastomosis can be easily done with keyhole surgery. This is one of our patients underwent this kind of sleeve resection a few weeks back. Another important thing is mediastinal lymph nodes. Mediastinal lymph node also very common among our patients, even early stage of lung cancer. You can see in this video, it's early stage of upper lobe lung cancer with multiple mediastinal lymph nodes. So how do you assess? Are you just abandon the surgery thinking of it is advanced disease? Because they are endemic of tuberculosis and other diseases. So we have an option, mediastinoscopy, as well as video-assisted mediastinoscopic lymph node dissection. So similar patient, if you present to us, if you get this kind of patient, what we do is, we do dissect all the mediastinal lymph nodes with video-assisted mediastinoscopic lymphadenectomy. By doing that, we can stage the disease by labeling each lymph node station and analysis with histology, as well as we can give a good clearance. It is staging-wise as well as therapeutic benefit for doing that video-assisted mediastinoscopic lymphadenectomy. So, not only the curative aspect, for palliative aspect, significant number of our patients present with pleural effusion associated with lung cancer. There we need to do thoracoscopy for the biopsy as well as pleural disease. This is again 80 years old lady presented with upper lobe tumor. You can see that collapsed upper lobe with multiple pleural deposits. But if you notice, the lower lobes are very well functioning, very well expandable. There we can do the biopsies and do the pleural disease straightforward. Yes, then they will have a complete expanded lung for next stage of treatment, and you can do pleural disease. On the other hand, this is different scenario. This is 38 years old lady presented with upper lobe non-small cell lung cancer, but her presentation is different. This lung is completely collapsed and there's a clot around the lung. This clot is mainly fibrin with tumor cells. If you do a pleural disease without releasing the lung, ultimately ended up with totally collapsed lung. So they can't go for next step of treatment because of collapsed lung. They frequently get infected. So what we do is we do tumor decortication to release the lung, to re-expand it completely. Following this kind of complete release, we can do similar talc portage to do talc pleural disease. So what are the quality metrics and outcome of keyhole surgery? Oncologically outcome-wise, margin status, lymph node yield, disease-free survival, overall survival, and local recurrence rate are same or even much better. And perioperative outcome-wise, conversion rate is we can maintain by having good regular practice and good training. And operative time, blood loss, complication rates, and length of stay and 30-day mortality also in acceptable level in keyhole surgery. The future directions are we can utilize advances in imaging, advanced imaging integration and fluorescence guidance surgery for the lung resection and specific lung resection and single port and robotic platforms and AI-assisted surgical navigations. And further, we can perform minimal invasive lung surgeries for complex locally advanced cases and novel hybrid procedures we can adapt. In conclusion, minimal invasive thoracic surgery has become integral part of thoracic oncology. And with continued technological advances and growing surgical experts, continue to expand its application. So I think that you have found the answer for my first question. Thank you very much.
Thank you very much for that excellent speech on thoracic surgical topic. So moving forward, Dr. Dhammike will introduce our next speaker.
So we'll move on to the last talk of this symposium. We have a lecture on management of malignant pleural effusions, an update by Dr. Rakesh Panchal. Dr. Rakesh needs no introduction. He has delivered a fantastic lecture on pneumothorax just a while ago. So it's over to you, Dr. Panchal to deliver your talk.
Thanks very much. Yeah, I'm stepping in for Professor Nick Maskell for the talk this afternoon. So I'm going to talk to you a little bit in the next 15 minutes or so about factors influencing malignant pleural effusion management, a review of the guidelines, and how we can optimize pleurodesis and the role of indwelling pleural catheters. So the burden of pleural disease is rising. In the US and the UK, there is statistics already available, and even on Indian cancer registries. Dr. Moorjaria spoke about lung cancer screening, and obviously that's going to pick up effusions. Patients are, in the UK, you can't leave RED without having a CTPA performed, so that's picking up pleural effusions. And people are living longer, and there's better oncological management. So we need efficient pleural effusion management strategies. This is just a summary of the trials that have happened in the last 10 years in the pleural sphere. And there's been a huge expansion on how we manage effusion management. I'm not going to go into detail of this, but there's a nice little summary of the evidence out there. So what's the ideal treatment for a malignant pleural effusion? Well, you want to improve breathlessness, quality of life, be minimally invasive, and eliminate the time in hospital. And what are the options we've got? We can drain the fluid and seal the pleural cavity. We can do a therapeutic aspiration, chest drain talc, thoracoscopy and talc, or an indwelling pleural catheter. So what factors influence management of an effusion? Well, we want to identify who's going to benefit from drainage, who's going to get fluid reoccurrence, who has got a non-expandable or trapped lung, who will benefit from, let's say, an indwelling pleural catheter or just simple talc pleurodesis via a chest drain? And how do we minimize days in hospital? And obviously, depending on where you're practicing medicine, what's the best value for money? So there are the European, American, and British guidelines on management with pleural effusion, which you'll be familiar with. So the American guidelines say that if you've got a malignant pleural effusion and your lung is likely to re-expand, you can either do talc pleurodesis via a chest drain or insert an indwelling pleural catheter. Similarly, the British guidelines say that if you think someone's got a trapped lung or a non-expandable lung, there's no point putting a chest drain in. Put an indwelling pleural catheter in or do a therapeutic aspiration. But if they do have an expandable lung, again, there are a number of options available, chest drain or an indwelling catheter. Now, I know indwelling catheters aren't available in Sri Lanka at the moment, but I think there are plans to introduce it in due course. So we all know what pleurodesis is. You need good apposition between the viscera and parietal pleura. You want to invoke an inflammatory response, lead to some coagulation and decrease fibrinolytic activity for the pleurodesis to be successful. So what's the best definitive treatment for patients with a symptomatic malignant pleural effusion? Well, you've got chemical pleurodesis, talc pleurodesis, surgery, and IPCs. So let's talk about chemical pleurodesis. So I saw this slide a little bit earlier, and I think Dr. Bodhika had asked me about doxycycline. You can see this is sort of a hierarchy according to the Cochrane review of pleurodesis agents. And talc remains the number one. And you can see doxycycline sort of fair way down, and iodine on this was supposed to be better than doxycycline, for example. Does anybody know what viscum is? Viscum alba. There's a clue there. It's not Christmas yet, but it's mistletoe. So in some parts of Asia, mistletoe abstract, I think it's available, the trade name is Fraxin, is a pleurodesis agent. Is anybody aware of viscum alba or has used it? No. So what are the complications of talc? So I know talc is hydrated magnesium silicate. And in years gone by, people used to use small particle talc, and there's always a concern about chemical pneumonitis or ARDS because some of this used to get absorbed or enter into if you've got a very raw, inflamed visceral pleura. We now use graded talc, and it's much less of an issue. So what determines pleurodesis success? So the Time 1 trial looked at the size of the chest drain and whether you're giving NSAIDs or opioids. Now, when I was an SHO, we used to be told if someone's on a non-steroidal, don't give patients non-steroidal anti-inflammatories for analgesia following pleurodesis, because the theory was that it reduces the efficacy of the pleurodesis. So it's an effective analgesia, but we generally avoided it. But that was based on small animal studies. Similarly, we now have Seldinger chest drains, which are smaller. And there's a question about, does a small Seldinger chest drain, is it sufficient for pleurodesis? And I know one of our colleagues in the audience was asking me about an 8 French catheter, and I suspect that's fairly small because you think you might get blocked, but we can talk about that. And this is one of the studies. So in this Time 1 trial, they randomized patients to a 24 or 12 French drain with NSAIDs or with an opioid. Okay, and they looked at pain scores and pleurodesis success rate at 4 weeks and 3 months. And in terms of analgesia, there was no difference using NSAIDs or opioids. Perhaps opioids were better within the first 8 hours. And how about chest tube size? Obviously, a larger drain was more painful. But in terms of pleurodesis success rate, perhaps it was a little bit better with a larger drain, 10% difference at 3 months with a 24 French drain. But there's no difference with NSAIDs or opioid use. So if you are going to pleurodese someone, you can use NSAIDs if you want to. Okay, so that sort of old theory of it reduces the efficacy of pleurodesis is out. I mentioned iodine earlier, and obviously that's quite fairly widely practiced in Asia still. It invokes an inflammatory response. The mode of action is not entirely clear, but there's always a risk of thyrotoxicosis and chest pain, and also iodine toxicity because it's excreted renally. From small-scale studies, the efficacy seems quite good, but obviously these are small studies which are prone to publication bias. So talc poudrage or talc slurry. So when we give it talc, we can either put it via a chest drain on the ward, or we can do it thoracoscopically. We've always felt, well, thoracoscopically, doing poudrage while you're doing thoracoscopy, it's under direct vision, you're able to direct where the talc is administered. It was probably better, okay? But there's been 2 studies now. There's the Dresler paper, which is over nearly 20 years old, actually. And then the TAPS trial, which was done in the UK, which showed that pleurodesis success rate, there was no difference in outcome whether you did it thoracoscopically or whether you do it via a chest drain on the ward. So this is in known malignant pleural effusion, by the way. Okay, so patients have a known malignant pleural effusion. So the recommendations are you could use either. My personal practice is if I know a patient has got a known malignant pleural effusion, I'll put a chest drain in and give talc on the ward. I will not take that patient to a thoracoscopy just to perform pleurodesis. I think you should only be doing a thoracoscopy in an undiagnosed exudative pleural effusion of unknown etiology. So you're doing it, A, to drain the fluid, B, to get a biopsy, and C, to put talc in if it looks malignant. How about surgery? Dr. Rasnayake was just talking to us very nicely about lung cancer surgery, but how about in terms of malignant pleural effusion management? We've got talc poudrage via VATS, pleurectomy, and pleural ablation. So I don't know how common mesothelioma is in this part of the world. Obviously, we've had, in the UK, we've been at the peak of the mesothelioma sort of crisis, and I think that we're on sort of a downward trend at the moment, but in many other parts of the world, mesothelioma is still common, and asbestos use has still been widespread. So in the MESO-VAT study, they had patients with malignant mesothelioma, and they randomized them to talc pleurodesis via a chest drain or a VATS partial pleurectomy, and they followed them up at a number of different time points. And they found out there was no difference. In fact, there was more surgical complications, respiratory complications, and air leaks, and a longer hospital stay with VATS. The AMPLE-3 trial by Gary Lee's group in Southeast Asia has just closed. So this was looking at VATS pleurodesis versus an indwelling pleural catheter and talc administered via an IPC. So that'll be interesting to see. I think the results should be available hopefully later this year. So an indwelling pleural catheter. Is an indwelling pleural catheter better than doing talc slurry pleurodesis? Because talc slurry pleurodesis that you do via your chest drain has a success rate of about 65 to 70%. So there is still a proportion of patients with the fluid is going to reoccur. And then you're either going to have the option of doing talc pleurodesis again, or a therapeutic aspiration, or perhaps inserting an indwelling catheter. So indwelling pleural catheter has been around for a while now. They're silicon-based, so it's more robust material. It's tunneled under the skin, about 5 centimeters in the same intercostal space. So it's tunneled under the skin with an exit site and an entry point into the pleural cavity. And it has a one-way valve on it for vacuum-based collection with a Dacron cuff, around which granulation tissue forms subcutaneously. There are pros and cons of indwelling pleural catheters. It's a day case procedure, avoids hospital admission. The patient and the family can be taught to drain it at home, and it avoids repeated procedures. But obviously there are complications of it, the aesthetic appearance, and naturally the cost. So the Time 2 trial and the AMPLE trial found that randomized patients with malignant diffusion to an IPC first versus chest drain talc, and they found that there was no difference in breathlessness scores and obviously reduced inpatient stay. You should certainly use IPCs in a trapped lung. So this is maybe where there's an endobronchial tumor preventing the lung from re-expanding or significant visceral pleural thickening. Now, it can be difficult to predict whether someone's got trapped lungs. So in this patient, you can see on the left, they had a large pleural effusion. There's no obvious meniscus sign, but we put a drain in and you can see the lung is not going to come up. So we had to take the drain out and wait for the effusion to reaccumulate when we put an indwelling pleural catheter in. Now, there are a few signs on there that might make you think that this patient could have a trapped lung. For example, the trachea is fairly central. There's no mediastinal shift. There's no obvious meniscus, and you can see the fluid sort of tracking apically, which is a little bit unusual as well. And you can see when the fluid was removed, the patient had a trapped lung. There's some interest in pleural manometry. It's not widely practiced. So you put this manometer catheter onto your thoracocentesis needle. And in a normal expandable lung, the pleural pressure drops very rapidly. But if you have a trapped or an entrapped lung, the difference, a lung entrapment means there's inflammatory visceral pleural thickening, whereas a trapped lung probably is due to malignant involvement. There's a huge negative intrapleural pressure and the pressure drops much more rapidly. And this was evaluated using this device in the pre-edit study looking at elastance. So if the elastance was more than 15 centimeters, you probably had a trapped lung and they put an IPC in, but if the pressure was much less, then the patient may benefit from a drain and talc slurry pleurodesis. How about ultrasound? I'm doing an ultrasound workshop at Walisara tomorrow and I'll mention this, but we use B mode and M mode ultrasound. So on B mode, if you see this reversed hockey stick sign, the patient may have a trapped lung as opposed to this fishtail sign where you think the lung will re-expand. On M mode, if you can see the cardiac impulse being transmitted through the lung with this sinusoid pattern, the lung is likely to re-expand as opposed to the absence of the cardiac impulse through the lung, which might suggest a trapped lung. If we do put an IPC in patients and we drain it aggressively, so we put an IPC in first line, can we give talc through it to increase the pleurodesis success rate? And in this study, they randomized malignant pleural effusion patients. So they put an IPC in, they drained them alternate days for 10 days. And if there was no trapped lung, they either gave saline as placebo or talc. And they assessed pleurodesis success at 5 weeks. And they found out if you administer talc via the IPC, you increase your pleurodesis success rate twofold. So the take-home message is if you're putting an IPC in somebody and draining them aggressively, or the patient undergoes autopleurodesis and the drainage stops, administer talc. So is IPC better than talc slurry? That was the question. So on the right here is the results of the IPC plus study I've just mentioned. And here is the TAP study looking at talc slurry or talc poudrage. So if you look at about 7 to 8 weeks, using talc slurry, the success rate of pleurodesis is 80%, whereas if you put an IPC in first and you gave talc, the success rate is around 55%. So I'm not saying the IPC is what we should be putting in everybody. Talc slurry still has a role and probably it still remains the best option for pleurodesis, so talc slurry via chest drain. So in patients without a non-expandable lung, you can offer indwelling pleural catheter or talc pleurodesis. Now, in my practice, I see a lot of young patients undergoing oncology treatment. So the oncologist may refer them to you saying they've got a malignant diffusion, can you drain it? But they're still having their oncological treatment. So you say to them, well, I'm going to have to admit you, put a chest drain in, and the average length of stay in hospital is about 4 or 5 days to drain the effusion and put talcing. And the patients, are young, they may have a family, they don't want to be away, it interferes with their chemotherapy regime. So then you might offer them an IPC. You can do it over a couple of hours as a day case and send them home. So I think you need to individualize the treatment to the patient. There are a number of guidelines available for IPC as well, which the references are here. So indwelling pleural catheters, in summary, you can use them first line, depending on if it's the patient's choice. And if the patient's got recurrent pleural effusion, then you should certainly consider an indwelling pleural catheter rather than repeated chest drains and talc pleurodesis. They have a role in trapped lung. If you administer talc via the IPC, if you do use an IPC first line, you will increase your pleurodesis success rate twofold. You can use it post-thoracoscopy. So you could do a thoracoscopy, a one-stop shop. So malignant pleural effusion, you drain it, do a biopsy, put talc in, and you could put an IPC in at the same time, and then you've avoided the need for any repeated procedures in the near future. I'm afraid we're not catching up with our cardiology colleagues anytime soon. When I showed you the pleurodesis agents, silver nitrate is a very effective pleurodesing agent. And these were drug-eluting IPCs where you put the IPC in and the silver nitrate sort of dissolved into the pleural space. And this was evaluated in the SWIFT study, and I'm afraid it was negative. So drug-eluting pleural catheters are not, or silver nitrate coated are not out there. I know that the title of the talk was Malignant Pleural Effusion, but IPCs do have a role in refractory transitive effusions as well, in renal failure, liver failure, which is quite challenging, and also heart failure. This is really exciting. So an indwelling pleural catheter gives you a conduit to the pleural cavity. And in mesothelioma, for example, we're involved in a phase 1 study looking at intrapleural treatments. And the benefit of giving an intrapleural treatment is you are able to use lower doses and you avoid the systemic side effects of chemotherapy, immunotherapy as well. So this is something that shows promise in the near future. And an IPC doesn't just mean indwelling pleural catheter, it also means indwelling peritoneal catheter. So this can be used in malignant ascites. There's been interest in combined approaches. Chuck Reddy in the US looked at this rapid pleurodesis protocol, doing thoracoscopy and IPC and TALC. And this was evaluated in the TACTIC trial in the UK. We participated in this, and this was presented at the Winter BTS in December. It was done across 11 sites. So the patients had thoracoscopy and TALC and were sent home, or had thoracoscopy, TALC, and an IPC. Now, there was no difference in breathlessness score, chest pain between the two, but they were saying that if you are going to put an IPC in a patient at thoracoscopy, you give them TALC at the same time, but there was no overall difference. So in summary, sterile TALC is the most effective pleurodesis agent. TALC slurry pleurodesis via chest drain does remain most efficient. If you are going to pleurodese someone, perhaps you could use a wider bore drain, but it's not absolutely necessary. I think in the UK, most of our practice is done via 12 French Seldinger chest drain. I think that's probably widespread used, or you could use an 18 French. There's no difference between thoracoscopy, thoracoscopic TALC poudrage and TALC slurry pleurodesis. So if you've got a malignant pleural effusion, put a chest drain in TALC, don't do a thoracoscopy just to manage a known malignant pleural effusion. Thoracic ultrasound can be used to look for pleurodesis success. IPCs can be offered first line, and if you are giving them first line, when you do think about removing it, give them some TALC via it. Definitely use it for trapped lung and recurrent effusions. The rapid pleurodesis protocol, I think there's no real difference between doing a one-stop aggressive protocol versus just doing thoracoscopy and an IPC. If you are going to do it, put an IPC and add TALC. And thank you very much. I'm just leaving you with some pictures from when I was here previously, when you used to have a school competition on pollution, and we were wondering whether, when I was in the education training committee for the BTS, whether we should do something similar. I know you've not done it this year, but I think some of these pictures were really nice, which I'd kept from a previous visit. Thank you.
Thank you very much for that excellent talk on management of malignant pleural effusion. Thank you very much. And I think we have time for a few questions from the audience, maybe 2-3 questions. If you have any questions, you can ask from this expert panel.
So my question is from Dr. Rakesh Panchal regarding when you are attempting pleurodesis with TALC or chemical pleurodesis, how much lung expansion, the minimum lung expansion you require? The BTS guidelines recommend more than 75%. Do you agree with that? And then the TALC slurry pleurodesis, when the success rate is calculated, when the studies that looked at the degree of lung expansion in taking into account the success rate.
Can you hear me? Yeah. So to have a successful pleurodesis outcome, the lung needs to be up. So yes, you're right. The BTS says more than 75% of the lung needs to be up. Otherwise, what's going to happen is if the lung is not up and you put the TALC in, or any pleurodesis agent, it's going to sit like a lump of chalk there, and then you're going to increase the risk of infection. There is some interest that if the lung isn't, you could put TALC in and then put the patient on suction potentially. Again, hang it over a drip stang to try and keep the lung up. But if the lung is, like I say, if it's not more than 70-75% up, I would avoid pleurodesing that patient because I think it's not going to work. and potentially increase the risk of complications, because you're offering somebody a treatment which is most likely going to fail. And like I say, you're going to have a lump of chalk there. You're probably going to lead to a malignant empyema. If anything, it's going to lead to infection. And I can't remember your second question. Sorry.
So that the estimated success rate of 70%, whether it has taken into account the degree of lung expansion on the studies that they are.
So I think if you look at pleurodesis's success rate, I gave you a overall figure of about 65, 70%. Some studies say 80, 90%, some say a lot less. And I think there's such variable practice, as you say, depending on how much lung expansion there was. So that's just a pooled figure I've given you. It's not. Okay. You could try suction, okay? But I think if the lung's not coming up despite that, then I think I would avoid pleurodesing them. And I'd have, in my practice, a much lower threshold for putting an indwelling pleural catheter in. And as I say, this is something I think here, the pulmonary community is looking at embracing, hopefully in the near future.
Okay.
I think do you use indwelling pleural catheters? I think you.
No, we don't.
You don't, but you inserted them. I think you said.
No,
no,
never.
you haven't.
No.
Okay, fine.
So, if I have a question, if I have time for one more question.
Yeah, of course. Yeah.
So, regarding the lung cancer screening, the low dose CT may not be cost effective for our country at the moment. So, is there any studies which looked at the efficacy of chest X-ray in screening lung cancer especially in high risk group?
So the current evidence that we have is for comparing chest X-ray versus CT. Those were the studies that were designed. So it would be difficult. We know very well that chest X-ray is not the best test compared to a CT. I'm not sure what the cost of a CT is, but in England it's less than £100. So I'm sure with time and utility, the cost will come down and it will become a useful tool. But in brief, I'm not aware, unless you're aware of any chest X-ray screening programs. I suppose you could do it, but you would do it anyway for a TB patient or whatever. So I'm not sure the benefit in terms of screening, if that makes sense. But I suppose if they've got symptoms, you could probably try and do a chest X-ray. But CT would be the way forward.
Thank you.
Good question, Adhavan. I'm a thoracic surgeon. So it may not be relevant in mass scale national screening, but we encounter a lot of patients being screened during medical checkups. Just doing X-ray, they detect, and we encounter stage 1 or stage 2 lung cancer. Maybe after surgery, they are curative. So, but there should be a place for X-ray because we detect a lot of early lung cancers during medical screening, just for other purposes, like say foreign travel and all, or medical checkups for government jobs, but may not be suitable for a national screening program.
Yeah, the other thing is, again, with chest X-rays, you're probably not going to find stage 1, stage 2 cancers anyway. I'm not saying you can't. I'm just saying
but we are not going to stop at
no, you don't
X-ray.
Stop your current
if you detect some abnormality in the X-ray, then we will definitely go for the CT.
Correct.
So then at that stage, we do proper staging, and we are not just doing surgery for X-ray. But after that workup start at that point.
Absolutely. But I wouldn't use it as a screening tool for cancer. That's what I'm trying to say. Sorry, maybe I wasn't clear. That's what I'm saying.
So in the interest of time, we'll wind up this session. And I thank all 3 speakers for those valuable and very insightful talks on the respective subjects. And I think we have to hand over the tokens of appreciations to the speakers.
The token of appreciation, I would like to invite first Dr. Jaymin Moorjaria, and thank you very much for participating or Respire, coming all the way from London. Thank you very much. Dr. Dhammike Rasnayake, consultant thoracic surgeon. Thank you for participating and enlightening us today with a surgical topic. Thank you very much. And Dr. Rakesh Panchal, again, thank you for participating and giving a valuable talk, coming all the way from London. And thank you very much again. Thanks.